Good morning, good afternoon, and or good evening, depending on when you are studying in this race to finish pathophysiology. We are back with part 2 for chapter 8, reproductive function. Such an interesting chapter that we are studying here. And we ended up on this slide at the end of our last lecture. And we're going to talk more about ovaries and their functions. Now, ovaries produce both hormones and oocytes, which are the follicles or the eggs in a female. And the hormones that the ovaries produce are going to be your estrogen and your progesterone and some testosterone. Females do actually have some testosterone. It actually comes from the adrenal cortex, but I think a little bit from the ovaries too. But anyway, the primary ones that we will talk about with a female are estrogen and progesterone, and those will give female their secondary sex characteristics. They also help the waxing and waning of the menstrual cycle. The ovaries contain very immature oocytes, which will be selected with each ovulation and each cycle. One will be selected, it will mature, and it will be ovulated. Now, this whole orchestra is regulated by hormones, and we have not spoken about these structures, so that's okay. We'll get into these structures in the future, but if you can dig back deep, if you could picture in the skull itself, there was a little saddle shape area right in the center of the skull. And in that saddle, I wonder if anybody remembers the name, it was sella turcica or hypophyseal fossa. That is where your pituitary gland is. It's this teeny tiny gland that sits in the center of your brain that is protected by the bottom part of your skull, and it controls all hormonal functions of the body. So we will absolutely be getting into these two hormones in the future, but I do think it's worth talking about right now. The pituitary gland, especially the anterior portion of the pituitary gland, secretes follicle-stimulating hormone and luteinizing hormone. And the thing to remember about those two is follicle-stimulating hormone helps the creation of sperm and a development of female oocytes. So that whole maturation from a very primordial basic follicle, and that's actually what they are called, into a mature follicle in a female that's going to be ovulated is orchestrated by this follicle stimulating hormone. And the waxing and waning of hormones, aren't we so lucky, ladies, with that waxing and waning of hormones, is controlled by the luteinizing hormone, and they kind of work together. Okay, so the thing to remember is that they're from the anterior pituitary. We'll take a look at where that is in the next few lectures. Follicle-stimulating hormone helps the regulation and the development of the follicles, which are your eggs and your sperm, and your luteinizing hormone helps that synchronicity of the hormones that are in the male and the female bodies. The fallopian tubes will be the next stop. That'll connect the ovaries to the uterus, which we looked at when we looked at the anatomical structures. The fallopian tube, I just want to make note, is extremely thin. When you cut that and look at the inside, it's like the width of a human hair, the actual opening in the center of the fallopian tube. So I want you to make note of that, because if we get inflammation that travels up through the uterus, such as we do with STDs or pelvic inflammatory disease, do you think that inflammation is going to cause problem in those fallopian tubes? Absolutely. Okay, so just make note of that. So it extends actually from the ovaries to the uterus, because that's the way the egg will travel. But they go into the fallopian tubes, the fundus of the uterus, which is that top of the uterus. The fundal measurement as a woman's stomach grows in pregnancy is the height from the pubic bone up to the top of the uterus. I think it's worthy to go back here if I didn't make note of it. I think I did in the last lecture. You could see at the top there is the fundus of the uterus. Okay. So the whole job of the fallopian tubes is to guide that oocyte or ovum down its tube and hopefully connect it with sperm in the fallopian tubes. I have a great picture of this so you can remember where things happen in the next few slides. And it moves the sperm and ova towards each other. If they yoke together, they form what's called a zygote. Zygote means to yoke together. That's the initial stage of an egg and a sperm joining together. Now, if that egg that's been fertilized progresses to replicate its cells and start growing in the fallopian tube, you get what's called an ectopic pregnancy. And this is a pregnancy that occurs outside of the uterus, most commonly in those fallopian tubes. For some reason, something goes wrong and the fertilized egg does not make it down into the uterus, which is the normal site of implantation, and it grows in the fallopian tube. If you have a female who has extreme abdominal pain and vaginal bleeding, this is one of the things that you want to rule out, especially if it's acute and a recent finding. So the uterus is the site of fetal growth should a female get pregnant, and also the development area for the placenta. When a fertilized egg makes its way down from the fallopian tubes into that top part of the uterus, it's just a bunch of cells. And those cells turn into layers, and those layers give us all of the basic cells for all the parts of the body. And what that baby does, excuse me, is basically releases enzymes that digs away at the mother's endometrium, which is the internal lining of the uterus. We could see there in the layers. And those enzymes dig away into that nice vascular layer of the uterus, and the baby can start to get its nourishment directly from that blood supply. The other thing that that baby does is it keeps a little bit of scar tissue in the ovaries. I have it in a few future slides. Which develop into what's called the corpus luteum. And the corpus luteum will release progesterone from the ovaries until we have this placenta ready. So if a woman gets pregnant, it helps to keep that baby viable by maintaining the levels of progesterone from that corpus luteum that we see in the, and I'm going to back up because I'm not sure if I'm explaining this like I should. Okay, so the follicle develops, and you can see as it starts to develop, it develops into a mature form, and that's when it has this fluid-filled space around it. Okay, there's so much more. I'm just really trying to give you the basics because we have so much more to go over. Okay, but when you get this U-shaped fluid-filled space around the egg or the oocyte, this is when it will be ovulated. The area that's left, there's an interim phase, don't worry about it, will actually turn into a little bit of scar tissue called the corpus luteum. If a female gets pregnant, this corpus luteum will secrete progesterone until the placenta is mature and can release progesterone for the female. Okay, so corpus luteum in the ovaries will release that progesterone for the baby. If a woman does not become pregnant, and or after the baby is mature enough to get the hormones from the placenta itself, which is about 12 weeks, it turns into this scar tissue here called corpus albicans, which means white scar tissue. Okay, so corpus luteum stays intact if a female gets pregnant, only if she gets pregnant and releases progesterone, so the baby stays viable. Okay, after 12 weeks, the placenta takes over as a vascular organ that feeds and nourishes the fetus, but also it releases the hormones that fetus needs to stay alive. Now, with the uterus, if you look at a female from the side, and I do have a picture of this, the normal position is anteflexed, and that means that the uterus is tilted forward. And if you think back, if you could picture it in your head to when we looked at the uterus, remember I said it can push down on the bladder, and it's because it's tilted forward in this anteflexed position which is its normal placement. The reason that it's important to know anteflexed is the normal position is because in some females it can be tilted back, which is retroflexed. And that's bad because it's more difficult for a female to get pregnant when the uterus is tilted in that position. Anatomically speaking, when a male penetrates a female, the penis will move towards the front slightly just from the tilt of the penis and the way the vagina is shaped. So when he ejaculates, it's more of a straight shot per se into that anaflexed uterus as opposed to retroflexed. You won't have as much sperm go into the cervix to go up into the uterus. You can also get a bend in the uterus backwards. So there's some things that can happen with that placement. Now, the layers of the uterus itself. The endometrium is the mucosal inner lining. This is the lining that builds up when we get our period and then sloughs off when we menstruate. Okay, well, it builds up during, I should say, before the menstrual period, and then it sloughs off during menstruation. The middle layer is the myometrium. Always remembered it as myo, middle. It's the muscular inner middle lining, and that is the muscle that will, contract when we're contracting to push the baby out. The perimetrium is just a serous membrane on the outside, and it actually helps to contribute to holding the uterus in place. Now, the cervix is the tip of the uterus that we looked at, and it looks pretty thick. It forms that little canal we looked at previously, and I just want to make note that that cervix will thin and efface as a woman gets close to delivering, as you know. So it goes from fairly thick, like 3/4 of an inch, to, thinned out and effaced, which is kind of an interesting little sidebar. Now, let's do a quick little question time. Now, instead of like your usual question, I'm trying to get you to think here. Okay? Don't look at the top because I just noticed that that is there. What is this? Okay? So if we take a look at this picture versus this picture, what do you think this is? So this is a female from the side. Here's the rectum. Here are the gluteals. Here, I should say, the colon and the rectum. Here's your anteverted uterus, okay, which is tilted forward. And it's tilted forward over the bladder. That's why it gives pressure to that. Now, if we compare that to this picture, you can see, if I bring it in closer here, can't seem to get a hang of this. I apologize. Let me turn this off. Hold on. And there's the answer right there. All right, bringing it back into normal view, this is going to be a retroverted uterus. Sorry about that. Okay, so if you look at the right, you can see that retroverted uterus and how it's pointed backwards as opposed to that tilting forward. The picture at the bottom, I just honestly did not want to put a real picture in of this, and you probably already know what I'm talking about. This is going to be one of those ectopic pregnancies in the fallopian tube, and it just makes me sad. When you look at it in a actual patient, you could see the distended fallopian tube, which in a normal female is very thin. I can't really think off the top of my head, maybe half the width of your pinky finger, give or take. I'm sure some of you have seen that in surgery. Many of you, I'm sure. So this is an example of that ectopic pregnancy. All right, so menstrual cycle. Yay! Average age of onset is approximately 13 years. It varies, okay, from person to person. And this is shedding the inner lining of that endometrium. And we actually build up layers. I'm not going to get into the layers. But it is approximately a 28-day cycle. This can vary from female to female, though. And there's 3 phases that I'm going to show you on the next slide. I have a really good visual. There's menstrual, There's proliferative, where that inner lining builds up again. And of course, it's building up to create a nice vascular layer should a female get pregnant. Don't forget, when the embryo, soon to be fetus, embeds on that endometrium or that inner lining, it needs that nice thick blood layer from the mother to survive for a while. So it needs that nice thick endometrial layer. If a female does not become pregnant, it will go through the secretory where it secretes the inner lining, which is menstruation as well. Okay. Each phase is marked by changes in hormonal levels, and it obviously will repeat until pregnancy or menopause. Here is a great chart. Okay. And this has a multitude of information. Just to make note, here's your pituitary gland. They're representing this on the inner aspect of the brain. The anterior pituitary is what releases that follicle-stimulating hormone and that luteinizing hormone. Those two hormones are regulated by actually the hypothalamus and what is known as gonadotropin releasing or gonadotropic releasing hormone. I know that's a chunk of change. We're actually going to go over that in endocrine. So, but it's pretty easy if you look at the word. Gonad means gonads. Gonadotropic releasing hormone is the hormone that helps to stimulate these two main hormones, follicle stimulating hormone and luteinizing hormone. Okay? Those two hormones regulate the development of the follicles, as I said, and the regulation of sex hormones, which will be your testosterone, estrogen, and progesterone. Okay? Yeek. We'll go over that again, I promise. If you look at the cycle, so let's start by going over the ovarian cycle. So all of these things are happening at the same time. So let's put it in reference. The developing follicle, and this is follicular phase, and this is luteal phase. This is because this is when the follicle is developing, and this is when the corpus luteum is developing. Okay? All right. So you can see here the development of the follicle. And it goes, as I said, from primordial, which is the most basic, to what's called your secondary follicle. The secondary follicle is the maturation or the maturity phase or step right before ovulation. Okay. Now, during the luteal phase, the corpus luteum develops. And remember, that will stay intact if a woman gets pregnant to release progesterone. If she doesn't, it turns into scar tissue. Okay, so that's what we're talking about, looking at all these hormonal changes. The next step, actually, that I'd like to go through to make it fairly easy, okay, is the menstrual cycle. Here's your menstrual phase where you have your menses. Okay, the proliferation phase is when that lining is growing, and at day 14 is ovulation. Premenstrual, they say, is secretory phase. I think that's confusing. I won't ever ask you that. I would just say premenstrual, I think, because secretory sounds like it's secreting, right? And then menstrual phase. And you can see how nice and thick this represents the endometrial lining, how nice and thick that gets. So that way, if we ovulate the blastocyst, it would be the developing baby, let's just say, can embed itself into the maternal uterine lining. Okay. Now, during this whole cascade of events, we have gonadotropin cycle. These are your gonadotropin hormones, which are just your FSH and LH. You can see they will peak right before ovulation. I think that's a good thing to know. Okay? And then they kind of calm down, and then they build up, and they calm down, they build up, and calm down. Okay? Now, as far as the actual female hormones, estrogen will peak right before ovulation, and then there's a second little peak that happens. Progesterone progestation peaks during that luteal phase. Okay. And if a woman gets pregnant, both of these hormones will stay at higher levels, guys. Okay. This is only what we're seeing, representing if a woman does not become pregnant. Okay. And that progesterone helps to keep the viability of the fetus should the female be pregnant. If she is not, this is why we feel so good when we get our period. All those hormones drop off. We're like, whoo, I feel normal. That's a different story. Anyway, all right. Maybe I just feel normal. I don't know. All right. So pregnancy, if a female gets pregnant, fertilization will happen in that uterine or fallopian tube, and implantation will be in that upper 1/3 of the uterus. The egg and sperm form what's called a zygote, which means to yoke together. That same zygote transforms into what's called a morula, which is just a little ball of berry-like cells. That will form into a blastocyst, which actually starts to put what'll be the future baby on one side with a fluid-filled sac on the surrounding it. And that blastocyst turns into 3 layers of cells from which all of our organs grow from. And there's so much more. I'm trying to keep it down to the basics. Okay. All right. So here is that fertilization and implantation. And you can see fertilization should happen in the fallopian tube or the uterine tube. Cleavage is just when it starts to divide and you get multiple cells. And if you look closely at that picture, morula actually means little berry. It looks like a little berry. As it enters into the uterus, it turns into a blastocyst, which should implant in that endometrial layer. If the pregnancy, and there's so many more steps, I'm just trying to give you some basics. If the pregnancy continues, the baby will develop eventually into this little fella that looks like a person, which is pretty cool, surrounded by amniotic fluid. And you can see the placenta here, okay, and the uterine wall. And the reason that I wanted to point this out is the baby's blood supply that comes into the placenta through the umbilical cord goes into what are called villi or chorionic villi. And what happens in the placenta is the mother's blood supply comes ever so close, but guess what it does not do? It doesn't intermingle. And this is why we can keep, in the initial phases, antibodies separate with Rh factor, because we're keeping the blood supply separate. Okay, but that's a whole complicated thing that we spoke about in blood. I'm not going to go over again. But so basically what happens is we will transport substances through the tissues to each side, and it can cross over to each, which is kind of cool. All right. Moving on, after a woman has reached a certain age, approximately 46 to 50, give or take, if she goes through 12 months or more without her menstrual cycle, it is considered menopause. The thing about this, as I'm sure you all know as a sidebar, is as a woman gets closer to menopause, she starts to release more and more eggs. She becomes more fertile, per se, especially from multiple births. So, as a sidebar, women as they reach menopause should be extra careful, or they might have a little surprise. So vagina is basically just a passageway for sperm to get in, babies to get out, menses to get out, okay, for intercourse. Now, there are some things, there's not any glands, believe it or not, throughout the vagina. There are glands at the opening, and I have a picture of them. They're Skene's glands and Bartholin's glands. And the reason that I'm telling you that is where a female secretes her protective lubricating fluid for intercourse. There's a little bit of glandular secretion, I believe, through the cervix as well. The reason I want to point that out is Bartholin's glands can get infected and inflamed, and obviously it would be distressing for a female because it is near the vagina. So I do want to point those out to you if you've never had a patient who has had that before. Now, hymen is a thin connective tissue that's usually in people who have not had intercourse and or are not into a lot of sports. A female can actually rupture her hymen even just with intense sports before she's even had intercourse. And the book had some interesting pictures. I won't ask you about the types, but you can see what those look like. And I'm sure that probably has been, familiar for you if you're working for an OB/GYN. But if not, I thought it was an interesting picture. Okay, external genitalia, mons pubis, we're going to just look at this. Labia majora, labia minora, clitoris, and vestibule is just the opening of the vagina. So let's just jump right to the picture. And mons pubis is where the hair is. Labia majora are the lips where the hair is. And labia minora are the inner ones where we have more of the mucous membranes. The opening or the vestibule would be here. Okay. And as we probably know, episiotomies would happen down in this region to help prevent rupture and tear. That always makes my poor anatomy students cringe when we talk about this, but gotta know. In the next slide, I have those glands that I wanted to show you. So this is basically the same picture. The greater vestibular glands, you can see, this is exposed. This would be as if you were to take the skin off a cadaver, just so you know. So they won't look like bulbs in a normal female, but they're right in this location. So if we go back to this female anatomical picture, they would be right at that posterior aspect. So a female can actually get these infected and inflamed, and it doesn't even have to be right about in this area. It would be a, pretty firm round mass. Doesn't even have to be through intercourse. Could be improper wiping. Who knows? Things spread, unfortunately, since we have so much bacteria in our body. And that, my friends, brings us to another question time. Implantation of a fetus in the fallopian tubes, and this would actually be more like blastocyst, but you get the idea, will lead to an uncomplicated pregnancy. What do you think? True or false? Thank you very much. I will see you in the next video.